I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's virtual events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's virtual events series.
Good afternoon, everyone. Thank you so much for joining us today. We are streaming live on Facebook, here on Zoom, and in some chapters, some of our medical school chapters. My name is Rebecca Kiesling, and I am the Director of Programs at the Benjamin Rush Institute. If you are not familiar with BRI, we are an organization dedicated to the education of medical students throughout the country, and we have international chapters as well, educating them on free market healthcare alternatives that they aren't getting in medical school. It's more important now than ever that our students are getting that education. We have seen so many changes in what they are receiving as medical students, and they aren't getting a full and broad education about what is different and what they can do as doctors, as healthcare providers, other than big government, big pharma, and the things that do not put the doctor-patient relationship first. That's where we come in. We are dedicated to that doctor-patient relationship. We are so thrilled to have this virtual event series, which we started after, in kind of conjunction with the COVID-19 pandemic. As medical schools closed down, we kind of switched seamlessly over to this live event series because normally our events are live. So we did that, and it's been wonderful to have these experts, these physicians, these policy experts join us and continue that education, not only for our medical students throughout the country, but also for our supporters. So I see a number of you that have been to a number of these since April. And if you're joining us again, thank you so much for coming. If you are new, thank you for joining us today. And you can look at our YouTube channel to get the past events that we've had. And we welcome you to subscribe, get notified, and see when we put new ones up. So one of the things that has happened because of the COVID-19 pandemic, we've all been spending a lot more time inside, a lot more time with our families. And I'm really excited about today's speaker because what he's going to do is talk about how Americans can have more control over their destiny while still promoting at a less expense the important social goals that give rise to government safety net programs in the first place. We are very excited to have one of the nation's leading thinkers on health policy with us today. The Wall Street Journal has called Dr. Goodman the father of the health savings accounts. Modern Healthcare says he's one of 4 people who have most influenced the changes shaping our healthcare system. John C. Goodman is president and CEO of the Goodman Institute for Public Policy Research, which is a think tank focused on public policy issues. He's a senior fellow at the Independent Institute and was the founding chief executive of the National Center for Policy Analysis. Dr. Goodman is the author of 9 books on a huge variety of topics. His newest book comes out next week, which is talking about what we're going to talk about today, a new way to care, social protections that put families first. He has authored numerous editorials in the Wall Street Journal, USA Today, Investors Business Daily, Los Angeles Times, and many others, and regularly appears on television, including CNN, CNBC, and the Fox News Channel. He regularly briefs members of Congress on economic policy and frequently testifies before congressional committees. Is the author or co-author of more than 50 published studies on such topics as health policy, tax reform, and school choice, all issues that are so prominent in what we're dealing with today because of this pandemic. Dr. Goodman received a Ph.D. in economics from Columbia University. He's more than qualified to talk about what we're dealing with today and what choices that we need to make in the coming months and years. You don't want to hear from me anymore. You want to hear from Dr. Goodman. So Dr. John C. Goodman.
Thank you, Rebecca. I'm still reeling a bit from that introduction. It almost makes me feel I should run for office. I'm John Goodman. I approve that message. You know, you never know, but at an event like this, you can always have an emergency call. But that's not the reason I'm holding this cell phone here today. I'm holding it because I want to make a point. There are more cell phones in the United States than there are people. You know, even the panhandler over on the street corner probably has a cell phone, but he probably doesn't have very good access to health care. If something goes wrong with my cell phone here in Dallas, Texas, or any one of a dozen places I can pop into without an appointment, and I can get low-cost, high-quality care. There are places that will send a technician to my condo and repair my iPhone in my home. There's a national chain. It's called iHospital. People who work for it are called eye doctors. But if something happens to me, you know, the average wait for a new patient to see a physician in this country now is 3 weeks. And in Boston, where we're told they had universal coverage even before there was Obamacare, the wait is more than 3 months. Amazingly, 1 out of 10 people who enter an emergency room in this country leave without ever seeing a doctor simply because they get tired of waiting. And so my question to you today is, why is the market so kind to my iPhone and so mean to me and you? And the answer, I think, is that this phone is produced and sold and repaired in a real market with real prices, where entrepreneurs know they can make millions of dollars if they meet our needs. Whereas over in healthcare, we have so completely repressed the market that none of us ever sees a real price for anything. No doctor, no patient, no employer, and no employee. We like to think that we're really different in this country from the Canadian healthcare system, and I've probably contributed to that view in my own writings. But the truth is, we're about 80% just like Canada. We bought into the same idea that the Canadians and the Europeans have bought into, and that is that no one should ever have to choose between health care and other uses of money. And what we forget is that if we're not choosing between money and health care, we're choosing between health care and something else. Now in Canada, when you go to a doctor, it's free. But in the United States, when you go to a doctor, it's almost free. Every time we spend $1 at a doctor's office, only 10 cents is coming out of our pocket on the average. The other 90 cents comes from an employer, insurance company, or government. We pay for health care mainly in the United States the same way the Canadians pay. We pay with time and not with money. You know, when you go see one of the other professionals, an accountant or a lawyer, or an engineer, architect, what do you call that outside area that you enter into? You call it a reception area. But when you go to the doctor's office, what do you call it? We call it the waiting room. Now, what we forget is that when you repress prices, when you repress market forces, what you do is you elevate the importance of non-price, non-market barriers to care. And there's a lot of evidence that I could go into that these non-market barriers to care are more important even for poor people than the fee the doctor actually charges. Now, what's a non-market, non-price barrier to care? Well, how long does it take you on the telephone to make an appointment with a doctor? How many days, weeks, or even months do you have to wait before you see the doctor? How long does it take you to get from your home or your office to the doctor's office and back again? Once you're there, how long do you have to wait before you see the doctor? These are all non-price barriers to care. Consider a Medicaid mother who doesn't own a car, but has to go to the hospital to have a blood test. So she takes a bus to one bus stop, she changes, gets onto another bus, gets to the hospital, has to wait there, gets her blood test, reverses the whole process, and it takes a whole day just to get a blood test. that she could have gotten in a few minutes at the Minute Clinic across the street if only Medicaid paid for the Minute Clinic services, but in fact it does not. Now, in the United States today, there are about 43 million people on food stamps, and people on food stamps can go in any supermarket and they can buy the same food that you and I buy. They pay the same prices we pay. In the old days, you'd put the food stamps down, put cash on top of it if you needed to top up. These days, there's a plastic credit card that people use. But you never hear it said that supermarkets aren't taking any more food stamp customers. Poor people have access to supermarkets. The worst that can happen is they have to get on a bus and go a couple of miles, but no one's turning them down. Now, over in the healthcare area, we have about 70 million people today who are on Medicaid, and a lot of these are the same people. And what's the biggest problem that people on Medicaid have? It's finding a doctor who will see them. Now, I was in Boston not long ago, and as I sometimes do when I'm in another city, I asked the cab driver, she's a female, how the healthcare system in Boston was working. And she says, well, she was on Mass Health, which is their Medicaid program. And she said, trouble was she had to go down a list of 20 doctors before she found one that would see her. And I said, well, were you going down the yellow pages? And she said, no, I was going down the list that Mass Health gave me. Now, that's what they call universal coverage in Boston, Massachusetts today. Now, what happens when Medicaid patients can't find doctors who will see them? Well, they go to community health centers, or they go to the emergency rooms of safety net hospitals. Here in Dallas, it would be Parkland Hospital. And there they can wait 3, 4, 5, 6 hours, depending on the time of day and day of the week. Now, if you're bleeding all over the floor, they're going to see you pretty quickly, but if you're not, you could spend many, many hours waiting for care. Now, while all that's going on, we have more than 2,000 walk-in clinics across the country, and Minute Clinic is the one in CVS pharmacies. And the reason for the term Minute Clinic is that they want to communicate that they know your time is valuable as well as your money, and it's very reasonably priced. The problem for the Medicaid patients is that here in the city where I live, Minute Clinic charges about $70, $75 for an earache or sore throat or something like that. But Medicaid only pays half that price. And unlike the food stamp program, over in Medicaid, it is illegal for the patient to add to the Medicaid rate in order to pay, the market price for the services that they want. It's not only illegal, it's criminal. If the nurse at the Medicaid at the Minute Clinic took money from a patient and put it in her pocket, or put it in her purse, she could go to prison. So we've criminalized the kind of behavior that is encouraged and condoned over in the food stamp program. We could enormously increase access to care in this country just overnight if we would just allow low-income people to purchase health care the same way they purchase food. But we're not doing that. So the first point I want to make with you here today is that if we want to change our healthcare system, if we want to liberate it, if we want to make it work well for patients and for providers, we have to begin by liberating the patient. And then we have to liberate the doctors. Now, doctors are the only professionals in our society who are unable to repackage and reprice the services they offer to the market. So every other professional, lawyers, accountants, architects, engineers, every one of them can change what they offer to the market and change how they price it whenever conditions change, whenever technology changes, whenever consumer preferences change. That's the way markets work. But doctors are slaves to a third-party payment system that really begins with Medicare, and they're unable to get out of it on their own. Now, I would guess, almost a century ago, all the other professionals learned that the phone is a very useful instrument for communicating with clients. But Medicare, when it started, they drew up about a list of about 7,500 things they would pay doctors to do. And so you have all these tasks, and you have a price next to each task, and it differs depending upon the community where you live. But there's no worse way to pay a professional. Okay, you never want to pay a lawyer that way or an accountant that way, but that's the way we pay doctors. And one really bad thing about paying doctors that way is that if you draw up a list of all the things you want the doctor to do, you're almost certainly going to leave things off the list. You can't think of everything. And of course, one of the things that Medicare left off the list was the phone. And then toward the end of the century, all the other professionals discovered email. So everybody's emailing everybody. I email my lawyer, I email my accountant. And my accountant and my lawyer charge me for phone calls. They charge me for email. They charge me by time. They don't charge me by task. But doctors are not paid that way. And as a consequence, no one, as we entered this year, was emailing their doctor, with a few exceptions that I'll talk about. Now, with respect to phone, email, Skype, all of that sort of thing, it wasn't just that somebody left it off the list for Medicare. Congress actually passed a law making it illegal for doctors to consult with their patients by phone, email, Skype, or any other telehealth mechanism, except under unusual circumstances. If you were out in a rural area and not in your home, it was permitted, but that was it. As we entered this year, that was the law. Now, Trump administration has made significant changes that I want to go into in just a minute. But before doing that, I want to say something else about paying doctors by task. Jeffrey Brenner is a name that some of you may have heard of. There's a very famous article called Hotspots that you might want to look up and read sometime, because it says something very interesting about health care and how we pay for it in this country. But Brenner lived in, and still lives, in Camden, New Jersey. And I'm told that Camden is one of the poorest places in the whole United States. Nobody in Camden has private insurance. They're either on Medicare, or they're on Medicaid, or they're uninsured. So Brenner was a scientist, he was a doctor, he was interested in understanding things, so he went down the hospital records and he discovered that about 5% of all the people who lived in Camden were spending about half the hospital's resources. And so he went down the list of the 5%, and he started with a guy that weighed 600 pounds. And this individual was an alcoholic, he was a drug addict. He spent half the year in the hospital, and when he was in the hospital, he was abusing himself. So Brenner took this guy under his wing, and he got him to go to AA, got him off alcohol, got him off drugs, found out he was religious, got him to go to church, signed him up for some welfare programs so he could have some financial stability in his life. And pretty soon, this guy wasn't going in the hospital anymore. So the expenses of this guy, his healthcare expenses, went down, down, down. Well, Brenner's success with this patient was so remarkable that he established a small clinic and started taking in other patients with similar problems. Brenner once told me he could drive down the streets of Camden's and point to whole buildings. He could tell you how much that whole building was costing Medicare and Medicaid. And that's where the term hotspots comes from. Turns out that sick people who cost the healthcare system a lot of money tend to live near each other. I don't know quite why that is. But Brenner started doing this with more patients and basically getting them to change how they were living their lives. And when he did that, their healthcare expenses came down. Now, during the years of the Bush administration, I went to Health and Human Services, and I told them about Brenner. And I said, you guys should write Brenner a check for $1 million. And they looked at me astonished. I said, well, why should we pay Brenner $1 million? He's already doing what we want him to do. And this is the way bureaucrats think. You have to kind of coach them through basic common sense. And so I patiently explained, well, look, if you sent out a letter to every doctor in the country and said, look, if you can find a way to lower expenses for Medicare, we'll pay you something to do that because that's good for you and good for us. Well, that was the most radical thing they'd ever heard of. When Brenner, by the way, discovered I had said this, he called me up and thanked me for the idea. He approved of the thought of giving him $1 million. But here's the question I would pose to you today. How much do you think that Medicare was paying Brenner for these services? For saving Medicare millions of dollars, how much do you think Medicare paid Brenner? It turns out that it paid him virtually nothing. How much do you think Medicaid paid Brenner for saving the state government and therefore state taxpayers, but also we federal taxpayers, millions of dollars? The answer is Medicaid paid almost nothing. So why is Brenner saving money for the system but getting nothing back? And the reason is that those services that I described a little earlier, the things he was doing to cause patients to change their lifestyle and reduce their health care expenses, really are social services. They're not, in any event, they were not on the list of the 7,500 things that Medicare pays for. And that's yet another problem with paying doctors according to task instead of paying them for achieving good results. So lesson 2 today is if we want the healthcare system to work, we have to free the patient and then we have to free the doctor. And the third lesson is that we have to free the entrepreneur. Now, I'm sometimes asked, will the market really work in healthcare? And my quick answer is that the market is the only thing that really works well in healthcare. So if you show me a part of the healthcare market where there's no third-party payer, no employer, no Medicare, no Blue Cross, I would bet you that's probably a part of the market that's working pretty well. So since we have a lot of medical students on this program today, I'm going to bet that you don't know very much about cosmetic surgery. But give it another 10 years and even you might get interested in this market. But here's a market where we have package prices. So patients know in advance what they're going to pay. You know, this is the sort of thing that Donald Trump complains about, that you go to the hospital, you don't know what you're going to pay for anything. Well, in the cosmetic surgery market, that doesn't happen. So you know in advance what you're going to pay. By package price, I mean it covers the doctor and nurse, and this is if there is one, the facility. You know what you're going to pay. There's price competition. And over the last decade or two, the real price of cosmetic surgery has gone down, 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 as the real price of every other kind of surgery keeps rising. LASIK surgery is another example of a market where there's no Blue Cross, no Medicare, no third-party payer. And in the LASIK surgery market, we have price competition. We have quality competition. You get package prices. You know in advance what you're going to pay. The real price of LASIK surgery, like cosmetic surgery, has gone down, down, down over the last decade or so. Again, even as all the other surgical prices keep going up. Markets where there are no third-party payers operate like real markets. And most of the innovations, especially consumer-pleasing innovations in healthcare, have been outside the third-party payer system. Teledoc is a firm here in Dallas that has 20 million customers. But prior to this year, Medicare didn't pay for the service. Most large insurers didn't pay for it. Most employers wouldn't pay for it. Teledoc, with its 20 million customers, set up outside the third-party payer system and provided telephone consultations for patients. An incredible innovation, incredibly time-consuming and money-saving innovation for patients. Rx.com set up on the internet, and you can go on the internet and buy drugs, and it was set up to compete with local pharmacies based on price. And why? Because so many people were paying for drugs out of their own pocket. Here was another innovation. If Blue Cross paid all the drug bills, there never would have been Rx.com. So this is an innovation that came on into the market to compete for customers on price and on quality. And the studies show, by the way, that it is a better quality. They make fewer errors than your local pharmacy, and it turns out the cost was lower. These are just examples. We've already mentioned the walk-in clinics. Those started outside the third-party payer system. Now, eventually, as these things settle in, the third-party payers come along and decide, well, maybe we should pay for this since it saves money for everybody. But the third-party payer system is a bureaucratic system. It's a system that does not welcome entrepreneurs. And entrepreneurs have to prove themselves outside the system before they're welcomed. So we need to free the patient, we need to free the doctor, and we need to free the entrepreneur. Now let's talk about the Trump administration for a few minutes, because it's done a very poor job of talking about itself. For the last 4 years, the Trump administration has been in the process of radical deregulation of healthcare. And I mean really radical. And it's something that nobody knows about. It has not been reported well in the mainstream media or even in the healthcare media. But being able to talk to your doctor by phone or by email or by Skype is a perfect example. As we entered this year, as I said earlier, it was illegal. But the Trump administration was laying the groundwork for this. They wanted it to be legal, and they were pushing the edges of the law, making incremental improvements here and there. So when COVID hit and Congress decided, well, we have to do something, so they temporarily suspended that law, the Trump administration was ready. And had they not been ready, it would have taken another year, because somebody has to decide which of the 7,500 services that doctors perform can be done by telehealth. And what are we going to charge? We're going to pay the doctor the same for an audio consultation as a visual? How's all that going to work? Well, that takes time. In fact, it took many, many months of time. And so the Trump administration was ready. And very quickly, as of April, almost a third of all seniors in urban areas had at least one telehealth visit. And in the rural areas, it was 1 in 5. And this is the least computer literate segment of our society. And I know many people who said, my parents will never be able to do that. Well, their parents are able to do it, and they are doing it, and it happened quickly. So there's been an explosion of telehealth visits. I said earlier that the Medicare patients couldn't have this by law, but those of us who weren't old enough to be on Medicare didn't have it either, because the Facebook, Skype, Zoom, the way we're talking to each other right now, that violated federal privacy laws. So all that has been set aside this year, and patients and doctors are learning that they can communicate with each other the same way people communicate with their lawyers and their accountants and with other professionals, and it's been a real boom to medicine. And by the way, we're just at the starting point. We're just at the beginning of this revolution. If you go online to Best Buy, you can get a little kit, and it has an oximeter that you put your finger in it, and it tells you what your blood oxygen level is. And if you think you have COVID, that's really important, because COVID is a disease of the lungs. And so that's one of the tests you need. But from Best Buy, you get a little device you can put in your ear and analyze an earache and something for your throat, for a sore throat. And but most patients don't have these things. But as we move along, they're going to get them. And I think it's not unreasonable to think that maybe 30% of all the visits that used to occur at doctors' offices for primary care are going to start occurring in the home. And some of you may have noticed just within the last few days that CMS is now changing its rules on hospital-only care, so that there are a whole list of things that Medicare only pays for if it's done in the hospital. And now they're saying, no, a lot of these things you can do at home. You can have monitoring from the hospital. The patient doesn't need to be in a hospital bed. And so I really think we're not just talking about primary care. We're talking about all kinds of care that people haven't thought about. Person gets a knee replacement. He goes home, he's recovering. But the doctor needs to look at the knee again. And if the person has to get in a car and go to the hospital and climb the stairs or somehow get to the doctor's office so he can examine it, that can be quite a hassle. But it's unnecessary, because we can do it with telemedicine these days. We can port a camera at the knee, and it can be examined that way. So we're just at the verge of a huge revolution. And I believe a number of people have said that if Donald Trump would just talk about health care the way I'm talking about it right now to you, he probably would have won the election. His administration did some remarkable things that he didn't seem to know about and he didn't talk about. So telehealth is one of them. Another one is the ability to have a relationship with a doctor that we used to call it concierge care. And now it's called direct primary care. And all it means is that a patient has a relationship with a doctor, has his cell phone. And that means at night and on weekends, the patient can reach the doctor instead of having to go to the emergency room. And back when we called it concierge care, this was expensive. I mean, I used to know people who paid thousands of dollars for this kind of service. But there's a model that started in Wichita, Kansas, that is really an inexpensive version of all of this. And it's a model that's spreading all around the country. And now the costs, say, for a mother with a child would be $50 a month for the mother, $10 for the child, to get everything that a primary care physician provides to a patient. And that physician or that physician's practice is available not just during office hours, but also at nights and on weekends. So this is one of the really fast-growing areas of healthcare. Employers found out about it, and they started paying for this as part of their healthcare program. But before this year, employers were not able to put money into an account so that the patient could choose a direct primary care doctor of his or her choice. And that's another major change that occurred this year because of the Trump administration. Now they can put money into an account. If you're an employee, you can choose the doctor. You don't like the doctor, you can go to another doctor, but you control the money. And you control where that money goes, where your monthly fee goes. And it's a type of service that saves you time, again, as well as money. Now, another really, really important innovation had to do with individually owned health insurance. Prior to this year, it was illegal for employers to buy insurance for their employees that the employees owned and could take with them from job to job and in and out of the labor market. So, for example, we're talking about Blue Cross. An employer could only buy Blue Cross group insurance for the employees. It could not buy Blue Cross individual insurance that the employees could take with them. And the Obama administration was so firm about this that they told employers, if we catch you doing it, we catch you putting pre-tax dollars into the pockets of employees so they can buy their own insurance, so we're going to fine you $100 per employee per day, or $36,500 per employee per year. And that's one of the highest fines in all of Obamacare. But beginning this year, all that changed. It was an executive order that President Trump signed a year ago, and it went through the regulatory process. And as of January 1st, employers can now put money into an account so employees can buy their own individually owned insurance. Really, really important innovation as we moved into the COVID world. And it would have been more useful had more employers known about it. They didn't know about it because the news media was not reporting on it. But more are now discovering it. And with millions of people losing their jobs and millions more at risk of losing their jobs, this is a really, really important innovation. So this year, for the first time, employers can provide this service for their employees. There's much more that Trump has done that I say Trump has done it, I'm not sure he's aware of it, but his administration has made health savings accounts far more compatible with chronic illness, so that it's becoming more and more likely that people will be able to have a health savings account for chronic illness. More needs to be done, but some major inroads there. The administration has made it easier to buy insurance tailored to individual and family needs. Something called ShortTerm Insurance has a long history. It used to be available for up to 12 months for people. It's gap insurance. So a student going from school to a job or going from job to job, just for short periods of time, people wanted certain basic coverage. And the Obama administration reduced that to 3 months with no renewals. And Trump comes along and extends that to 12 months, and you can renew up to 3 years. And not only can you renew up to 3 years, but you can buy a second kind of insurance that protects you so you can go into a second 3-year period and then a third and so forth, so that you can have insurance indefinitely. And what is interesting about this insurance is none of the Obama regulations apply. So there's no set benefits that it has to offer. It can ask health questions. And if you have health problems, this is not the market for you. You should be over in the Obamacare market. But there's been a huge increase in this market because of the Obamacare market, where prices have doubled. The typical deductible is 3 times what it is in an employer plan. And there's a race to the bottom on quality. In the individual market, it's increasingly difficult for patients to see the best doctors in the best hospitals. Here in Dallas, where I live, UT Southwestern may be the best medical research facility in the whole world, but you cannot buy individual insurance here in Dallas that gets you into UT Southwestern. They won't take you. Down in Houston, MD Anderson Cancer Center, one of the best cancer treatment centers in the country, they don't take Obamacare insurance. So we're seeing a deterioration in quality and increase in price. In fact, the cost of Obamacare is so outrageous that it's in a death spiral. Healthy people just aren't buying. There's been a huge decrease in the number of people who are buying that insurance who do not get subsidies. That's about 40% of the market, by the way. So I have, in this short period of time, covered quite a lot of ground. And in fact, I probably talked too long. I promise I'd give you all some time for questions. But that gives you an overview of what's been wrong and where we're going, and we need to do more of it.
Well, thank you very, very much. It was fascinating hearing from you. One of my favorite things, and this is something I tend to ask most of our guests here, but you touched on it a great deal, so I'm changing up my question a bit. I always ask our guests from it's kind of my question, about regulations that we have seen put on pause through various governors or even on the federal level because of the COVID-19 pandemic. You touched on a lot of those because what you talked about were things that President Trump and his administration actually have done already. Things that we have seen the Trump administration put into effect. So I guess my question is 2 parts. Because of the COVID-19 pandemic, we have seen a number of regulations put on pause. If you could pick one, what would you think? What would you hope we never came back? And based on the things that the Trump administration has done, what are you hoping that a Biden administration doesn't reverse?
Well, let me just answer in a very general way that everything that's happened is really temporary, that nothing I have described here today is permanent. And by that I mean that nothing has been blessed by Congress as part of law. It's not been codified. And even where Congress has been involved, such as in allowing Medicare patients to talk to their doctor by Zoom and Skype, that's tied to the virus. So when the virus goes away, that ability goes away. Most of what Trump has done, he's done with executive order. Well, okay, that can be undone by the next president. And a lot of what he did was undoing what Obama had done by executive order before him. So it's really important to realize that all these things that we like and we're getting comfortable with could go away. And I encouraged the Trump administration to actually make this a part of their campaign, that the reason that they should be back in office is to encourage Congress to codify these things. But they didn't listen to me, and they lost. So now we have Biden, but there are a lot of Democrats as well as Republicans who see the value in this, and it is my hope that we'll get bipartisan effort. And it needs to be bipartisan. Everybody needs to realize that The House now is in Democratic hands, but 2 years from now, it's likely to be in Republican hands. So the idea that this is going to be one-party rule it's just not going to work that way. So we need bipartisan consensus to make these changes permanent.
Yeah, I think that's 100% true. We have seen so much good in deregulation, whether it's, you talked about telemedicine being one, and having that ability to speak via the internet to your doctor, much like we've been able to with direct primary care. Certificate of need laws, things like that have been removed via executive order based either on the state level or the federal level. I did like what you said, and we have a few comments on this, about the administration themselves, the president himself not knowing about some of the things happening, and then, based really being Seema Verma that has really done a lot of the meat that what we've seen. So that was it was interesting that you said that.
No, Trump never talked about this. Maybe one press conference, he rattled off some statistics about telehealth, but he never held up the phone and said, "Look, I got this for you." And I think had he done that, had he said, "Look, yeah, I'm opening these doors for you, and I want to be reelected to make sure this continues, and this is helping you deal with the virus," he would have had a much stronger case to be made for being reelected.
Yeah, especially considering we're in the middle of a pandemic. It should have been a bigger deal. A question came in about do you know what percentage of hospitals use fee-for-service payment models? We had Keith Smith from Surgical Center of Oklahoma on a month ago, but this question is about what percentage use that model.
Well, Keith Smith and his operation, which I admire very much, is about one of a kind. But let's talk about some variations on that. He, for those of you who don't know, he has a hospital. He lists prices, and they're package prices, and you know in advance what you're going to pay for a knee replacement or hip replacement and so forth. Most hospitals won't do that, or they won't do it for you. And here's a little known fact about our healthcare system. When Canadians come here for their hip replacements and their knee replacements, and they come because of the waiting times in Canada are so long, that's a free market, and they don't come unless they get a package price in advance. So, and you can do what the Canadians do. You can have a package price just like that from the same hospital that will not do that if you do it the normal way. You have to do three things. You have to be able to pay in advance, and you have to be willing to travel, and you can't have a third-party payer that comes back 3 months later and say we're not going to approve that. So the Canadians have access to a free market relationship with our hospitals, but it's the same hospital next door that won't give you the same deal because they think they're going to get you anyway. But that's going on, and the whole medical tourism industry, which is quite large, people traveling for care, and it's happening a lot around the world, and it's happening to some extent within our own country, but hospitals don't like to talk about it. So the hospital that treats the Canadian patient and is right next door to you and gives the Canadian patient the package price doesn't want you to know they're doing it.
So one of the things that, it was interesting talking to Dr. Smith, because going back to CMS and Seema Verma, one of the things that the Trump administration was able to accomplish, which is such an enormous deal, and you touched on this a little bit, and this is coming from one of our students, is price transparency. Obviously a huge deal, because we did get 2 price transparency rulings come down. What do you think that this will do in the future of healthcare? How do we impose this on hospitals, on everyone?
Well, I think what everybody needs to understand is that in our third-party payer system, If you're a Blue Cross patient and you go in a hospital, the hospital does not view you as its customer. It views Blue Cross as a customer. And if you're a Medicare patient, Medicare is their customer. So the third-party payer is not only paying virtually the entire bill, but they're also very involved in what kind of treatments will be given and how the compensation is going to work. So the patient is an excuse for money to be exchanged between the third-party payer and the hospital. So the reason you don't have package prices in this market is because patients aren't paying with their own money. And since that's not happening, there's no price competition. And by the way, when providers don't compete on price, they don't compete on quality either. The two go together. So hospitals compete on amenities. If you look at an advertisement for a hospital, it typically tells you how nice the rooms are, how great the food is, but they don't tell you the price of anything. And so this system, there's a logic to it, and the logic arises from the fact that we, the patients, are not customers, and we do not control the money. But in those markets that I mentioned earlier, like cosmetic surgery, LASIK surgery, and so forth, when we're in control of the money, well, then you do get to know the price, and there's price competition and quality competition.
I read recently a Wall Street Journal piece that it's an editorial that talked about a healthcare reform piece that you worked on. I'd love to hear a little bit more about that. I know we don't have very long, and I should have asked this in when I introduced you. You talked a lot. I think you condensed pieces of that in what you were talking about before. Congratulations on that. I think it's wonderful. Perhaps it should have come out before the election, and it should have, we could have gotten a little bit more attention to what you were talking about. But I think it's important to at least touch on some of the things that you talk about in reform. I'm a huge proponent of advocacy. I think that once our medical students, and we have so many on here today, get that MD or the DO after their name, they become advocates. Like I am not a practitioner. And I'd love them to hear about what reforms that you think are just so important to take place, because as advocates, as future advocates with so much power, hearing it from you is going to be a big deal.
All right, come to our site. It's called goodmaninstitute.org, goodmaninstitute.org. And under publications, you'll find the publication Rebecca is talking about and the Wall Street Journal talked about. And it's something I wrote with Mary Fishbaugh at the Heritage Foundation. And it really described all the major Trump health reforms and described how much progress has been made, but it also went into what we need to do next. I mean, we've made important steps, but there's more that needs to be done. And we need the cooperation of Congress. Also at the site, you can sign up and you can receive things from us if you're interested. But that publication in particular, the Wall Street Journal talked about it after the election, but we wrote it before the election. And before the election, Rich Lowry at National Review said, Trump needs to pay attention to this because if he loses, it's going to be because of health care. And that was really prescient. He did lose, and in my opinion, he lost because of health care.
It's a great piece. It's a lot of really poignant reforms that we need to keep going. And as a huge proponent of advocacy, I think that's something that we really push for is, as we're not advocates, we're educators. And that's what BRI does, is we educate. But we do stress the fact that, the power of advocacy and what that MD and DO does for the medical students when they receive it. And so learning about the reforms that you're talking about, I think, is so important. I do want to give a brief nod to your new book. It's coming out very soon. New Way to Care, Social Protections That Put Families First. Can you talk a little bit about that?
Sure. COVID has shown us that our healthcare system has a lot of problems. And when you think about all the deregulation that we've had to go through in order to deal with COVID, that shows you how unprepared our healthcare system was for this. But it's also true that Social Security wasn't ready, and Medicare and Medicaid and the unemployment insurance system, all these safety net institutions were designed years and years ago, and they're inconsistent with the needs of modern families. So the whole book is about how we need to reform all these safety net institutions. And interestingly, it points to other countries that have found better ways of designing systems, Social Security, healthcare, unemployment compensation, workers' comp. We're stuck in a rut, and it's time to think about bringing these institutions into the new century.
I'm excited to read it. I think, just reading about what is included in it, growing too old and outliving one's assets. I'm a mom of 3, and one of my daughters just went into college. She's a freshman in college. It's talking about a lot of where I should be, but also my parents, and how to make sure that financially I'm doing the right thing. And from an economist, but I think what it's doing is my protections are correct. Not financial advice, but making sure that really we're following the right path and what I can do to make it better. And I think that's what's so important, that we're doing the right thing and how to make it better. There's a lot there. There's a lot of juice there.
Well, every country except the poorest of countries cares about what happens to people in their old age. And but they don't all do it the way we do it. In Singapore, you're required to save for your retirement. In Hong Kong, you're required to do that. In Chile, you're required to do that. What we've done in this country is no one's required to save for anything. You have to pay into Social Security, but every dollar we pay in gets spent the very hour, the very minute that we pay it in. So it's a Ponzi scheme. Yep. And as you get older and you expect to receive Social Security benefits, you're going to discover that there really is no money in the trust fund, and that in order to pay you benefits, we've got to get money from taxpayers. And it gets harder and harder to collect the money needed to pay the benefits, because we promise benefits that we never saved for.
And I think it's very poignant at this. I think the whole premise of this book is very poignant at this very moment, because we have seen people's savings go up in smokes because of the pandemic, and they are looking towards Social Security and things like that for their life savings, for how they're going to make it. So I think the topic is very poignant. I'm excited to read it. A question that just came in, you were talking about pharmaceutical companies, or not pharmaceutical companies, I'm sorry, pharmacies. What do you think about Amazon setting up their pharmacy online now?
Well, I like all forms of competition, and that's what we haven't had in healthcare. And in fact, for many, many years, it was considered totally unprofessional for doctors to compete. In fact, if you want to read a really good history of regulation of medical care and the role of the AMA and all of that, and it's a very unpretty picture, it's my book, Regulation of Medical Care, published by the Cato Institute. And you can get copies online from Amazon. But we have, healthcare is the most regulated industry we have, and all the regulations are designed to prevent competition. And yet in every other market, we, the consumers, benefit from competition. What is competition? It's people competing to meet our needs. And that's been so suppressed in healthcare that that we are living with a totally artificial system. So I like what Amazon is doing. I like medical travel. Obviously, I like the other things we've talked about today, like telehealth. All of that should have come years earlier, by the way.
So I'm not sure if you're aware of this. A lot of people don't follow what the AMA is saying about medical schools. Before COVID, the AMA had said, and this is a good one for you with a PhD in economics. The AMA had said that they are proponents of, while there's no business education in medical school. They did want to start some economics education in medical school. I personally have a small problem in that because I think it's going to be fairly one-sided. And I don't think it will be a complete education, much like a lot of things in medical school. What would you say to that?
That they should use my book Priceless, which I wrote sometime back, which is a free market approach to healthcare. But it's more than that. It's an approach to healthcare which examines all the perverse incentives, everybody's perverse incentives, the employer, the insurance company, the government. You can't understand what's happening in healthcare unless you understand what's in the self-interest of the people who are in the system, and almost always it is perverse. So those are the most important things to learn about the economics of healthcare. And so it doesn't work like a normal market. I can't imagine how bad the courses would be in health economics taught in medical school. Health economics courses are bad even when they're not in medical school. If you pick up any book with health economics written on the cover of it, you'll discover a book that has very little to do with reality.
I'm interested in that one. I think my boss and your friend has actually sent that to me. So here's one by someone that doesn't necessarily believe in all of everything that we're on board with, but I believe that this is an important question to talk about. Medical debt is a horrendous problem, and we might only have a few minutes for this one. Unfortunately, medical debt is a horrendous problem in this nation, absolutely, including those who are insured. Your proposals greatly increase the out-of-pocket expenses for patients, impairing access to care and causing personal financial hardship. An improved Medicare for all would eliminate these financial burdens. Your opposition seems to be on an ideological basis based on a faith in markets. Yet Nobel laureate Kenneth Arrow explained why healthcare markets do not work. A single payer system would assure affordable healthcare for all. A system based on cooperation is more patient-friendly than one based on competition. Will you ever field on your ideology? This is going to be a brief answer, so you don't have to.
I'm sorry, it was kind of funny. Well, Kenneth Arrow may have said there are problems with the market, but he never showed us how socialized medicine works better. I don't know why the listener or viewer thinks that I'm for patients paying more of the bill. I'm for patients controlling more of the money. That's a different idea. So for chronic illness, for example, I'm for patients controlling a budget that's given to them by the employer, insurance company, or government. We actually do that in Medicaid for the homebound disabled, and it works really well. When the patient controls the money, the services get better. When people have to compete to see who better serves the patient gets better service, just like a normal market. So I would just encourage that questioner to look at what happens in other markets and open the mind to how this sort of thing could also happen in healthcare.
I think those questions are important to talk about. One of the things that we do at BRI is we do encourage debate on single payer healthcare. It's something that we were having, and I hope maybe I can get you at one of our debates when we open back up, because that would be amazing. But it was something that we do encourage, and we were having some fabulous debates at our chapters about single payer healthcare, because I think there is a discrepancy. You don't want to pay for the poor. You don't want to pay for healthcare. And I think there's a discrepancy in beliefs about what it really means to not be for single payer healthcare, and to be for a different kind of system. So I think it's important for people to understand, to get the expert opinion on, even if it was very brief, about what that means. We are big on debates to kind of understand that especially things like that a little bit more.
Well, single payer means that government controls the money, and therefore government controls what's done. It controls who gets care, when they get it. And If you look at look at a country like Canada or Britain, you see that healthcare is rationed. And it's also rationed in this country, but it's rationed more in Canada, and it's rationed more in Britain. And in Britain, you have a big private sector where people go and pay out of pocket for stuff they were supposed to get for free from government. In Canada, people come to this country and pay out of pocket for services they were told they're going to get for free in Canada. So creating a big bureaucracy and giving it control over your health care is not the answer.
That's it. One of the things that we focus on the most in what we do, and I know that you do as well, is as we're promoting these kind of different options, it's promoting the doctor-patient relationship. The more that you take the government out, the more that the doctor and the patient can talk to each other and they can deal with their health care, and you take the government out of it. And really, that's what we're trying to do here, because nobody better. I want to thank you. I really do. I am so cautious of your time. I am so thankful that you were able to join us today. We are going to be putting up all the information for the Goodman Institute, Dr. Goodman's contact information. We are recording this, so all of this will be up on our YouTube channel and on our Facebook page, and we do tweet it out. There's many thank yous coming up all over the chats, Dr. Goodman, and I thank you as well. If you are not signed up for our newsletter, where you do get information about all of our next live event series, please go to our website at benjaminrushinstitute.org, and you can sign up for our newsletter to be just notified of whenever we're going to have new virtual event series. We will be pushing this recording out very soon in the next couple of days. And please go and look for Dr. Goodman's new book, New Way to Care, Social Protections That Put Family First. Dr. Goodman, thank you so much for your time. I really appreciate it. And so do all of us here at BRI.
Glad to be with you.
Thank you so much.
I hope you enjoyed today's edition of the Benjamin Rush Institute's virtual events series. To learn more about our educational programs and events just like the virtual events series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's Virtual Events Series.